Hi, everybody. We are going to give everyone just a couple of minutes to get logged on, and then we will get started. So, a quick couple of housekeeping items. My name is Brooke McGiver, and I'm the Director of Communications and Marketing here at Tim's Medical and a speech pathologist. And I'm honored to have Sara Charney with us this evening to teach us about voice. If you are interested in obtaining ASHA CEUs for tonight's presentation, we ask that you stay on the webinar for the duration of the event. If we go past the hour mark and you need to log off, no worries at all. You'll still get credit. We will put up the recording on our website sometime within the next couple of days so you can access the end portion if you miss it. And then the other aspect that needs to be completed is the survey. So I'll put the survey link in the chat, but if you're on your iPhone and you can't access it, it will also be sent out via email from Zoom. If for some reason you're not registered to receive emails from Zoom, don't worry. You can send us an email at tims-univ@tims.com and I will send you the link directly. And then lastly, if you would like a certification of completion, just send us an email at tims-univ@tims.com and we will get one sent over to you. And with that, I'll go ahead and hand over the floor to Sara. And if you have questions throughout the presentation, feel free to pop them in the chat or the Q&A and we will get them answered as soon as possible. Sara?
Awesome. Thank you so much, Brooke. All right, so let's see if we do this. I'll make sure my sound is shared. It's going to look like a blank screen at first, so don't fret. All right. Okay, Brooke, are we good?
Yes, we are good.
Amazing. Okay. Hi, everyone. So I'm super excited to be here. My name is Sara Charney, as Brooke said, and I am here to talk to you all about a comprehensive approach to voice therapy and hopefully go beyond the worksheets today. So I am receiving an honorarium for this talk from TimsU, but otherwise I have no other financial or non-financial disclosures. So just a little bit about me. I'm a speech language pathologist, specialized in voice, upper airway, and swallow disorders, as well as head and neck cancer management. I went to Vanderbilt for my master's and completed my clinical fellowship at Oregon Health Science University, OHSU. I also attended the Summer Vocology Institute in Salt Lake City, Utah. And I'm currently working for Mayo Clinic, Arizona still, but am working remotely now from Baltimore, Maryland. Long story. And for the extra voice nerds out there, I am the co-host of the Out of the Voice Box podcast. All right, so today I'm hoping to go over the what, when, and why of voice therapy. What does it really mean when we consider the whole person in this context? What are some barriers to progress in therapy? And is there a way to proactively overcome these barriers to progress? And how do we do this? And then we'll end with how we can counsel our patients and carry over these techniques to real life situations. So I'm going to ask everyone if they don't mind pulling out their phones. And if you're on your phone, you can join slido.com with this code. And on the next slide, we will also have the QR code, so don't fret. But basically, I just want to get to know you guys. So do you currently work with voice patients? And if so, do you work in an academic voice center? Do you work maybe in a private voice practice, general ENT practice, maybe an outpatient voice practice with a hospital system? Yes, other, maybe I couldn't think of another option, or no, but you want to or want to learn more about voice. So I'll give it a little bit. You guys are fast. Still climbing. And Brooke, if you want to text me the number, then I can always kind of gauge it, but just give it another second. Alrighty. Okay, awesome. Thanks, Brooke. Okay, it seems to have stalled. So let's see. Okay, wow. Okay, a lot. I know it got cut off at the bottom, but Okay, so outpatient voice practice within a hospital system. No, but you want to learn about voice. Love that. Oh, they're still coming in. Cool. Yes, other. Oh, I'll be curious. Work in private voice practice, general ENT, and some of you also work in academic voice center. So cool. Okay, so I kind of know who I'm talking to. This helps. So thanks so much for participating. Okay, so moving along. So let's zoom out for a second. What are the primary goals of voice therapy, right? So of course, the specifics will depend on the impairment, but overall, we want to restore optimal vocal function, right? Note that we're talking about optimal function, not always complete, depending on the severity of the physical impairment. But we want to make the voice as efficient as possible, right? Efficiency meaning more output for less effort. Another goal is to prevent or treat vocal injury, right? By providing techniques to reduce strain, education on vocal health, as well as strategies to help manage their current vocal demands. And of course, improve quality of life, right? That's what we do as speech pathologists by helping these individuals communicate effectively in a variety of environments and situations. So, what are the main components of voice therapy, right? As you'll see, the treatment techniques are just one part of voice therapy. Number one is education, right? We want them to know why they might be having their voice issues. This is where the evaluation is really critical. So, you can demonstrate visually with video stroboscopy exam, or maybe acoustically or aerodynamically if you have that, what is really happening. Then we do want to introduce treatment techniques and strategies with both direct and indirect treatments, including introducing exercises or techniques that they're stimulable for improvement with, maybe discuss ways to modify vocal habits, such as reducing coughing or throat clearing behaviors, help them manage their vocal budget, or help them optimize their hydration, or maybe provide recommendations for amplification, right, if that's what's needed. We also want to take into account holistic considerations. So, other outside stressors or other lifestyle factors or habits that may be impacting their voice. And of course, we want to help them carry over what they learn to real life. It's great if they can achieve their target voice with a particular exercise or in a therapy session, but if it's not carrying over to what they really need their voice for, what's the point? Remember, we do need a medical diagnosis by a laryngologist and visualization of the larynx prior to treatment, right? We not only want to know what is really going on, but we also really need to make sure that we're not missing anything that could be more malignant. I have stories. But also remember, SLPs are part of the diagnostic evaluation and treatment plan, especially when it comes to distinguishing diagnoses that maybe can sound similar, but have very different treatment needs, right? Such as muscle tension dysphonia versus laryngeal dystonia. So, speaking of diagnoses, there are many different types of voice disorders that come to us, right? Which are typically categorized into two main groups, organic or functional. Organic voice disorders include structural or neurogenic disorders. So that could be our vocal fold lesions, such as nodules, polyps, cysts, etc., as well as malignancies, right, like cancer, would be examples of structural disorders, whereas maybe vocal tremor, laryngeal dystonia, aka spasmodic dysphonia, and vocal fold paralysis or paresis would be examples of a neurogenic voice disorder. And then we've got functional. So functional dysphonia or functional voice disorders occur when there is a behavioral disturbance in how someone's using their voice with no obvious anatomical, neurological, or other organic cause, although these can co-occur, such as with muscle tension dysphonia, which can be either primary MTD, being without any other organic cause, or secondary, being in addition to an organic cause. For instance, maybe someone with a lesion with muscle tension on top of that to compensate for that lesion. We also have complete functional aphonia or dysphonia, often due to traumatic events or previous structural issues that maybe haven't resolved, but the body hasn't really figured out how to voice again. And then I am putting separately voice-related gender dysphoria that we would treat with gender-affirming voice therapy or surgery. But I do want to make that clear that we're not categorizing that as a pathology in this context, but I would be remiss to not mention it at all. Okay, so does voice therapy alone treat all of these disorders? Well, to answer this, we can think about voice therapy as being a primary treatment for many of these disorders or an adjunct treatment in addition to a medical or a surgical intervention. So, for instance, primary muscle tension dysphonia or vocal fold nodules are typically treated with voice therapy alone, although there can be exceptions to that. Whereas if the lesion's super large, such as a vocal fold polyp or of course a cancer, they would need a procedure to remove that lesion before voice therapy can be completely beneficial. So it's important for us to figure out if they may be a good candidate for therapy at all first, and if so, would it be best as a primary or an adjunct treatment? And this is where collaboration with their laryngologist colleagues are essential. Okay, so let's take a look at a common diagnosis we often see, vocal fold paralysis. So this patient is a 65-year-old woman who is found to have left vocal fold paralysis following a thyroidectomy. And in the operative note, there's no note of recurrent laryngeal nerve sacrifice, meaning as far as they know, the nerve is still technically intact, and she's only 2 months post-op, but this is greatly impacting her quality of life. So let's look at the scope. But first, for those of you who don't look at scopes every day, I just thought we would do a quick brief orientation. So we've got the back of the throat and the front of the throat. I hope you guys can see my cursor. Brooke, tell me if you can't, but this is the left side of the screen, and this is the right side of the screen. Or well, I should say, this is the right side of the screen, but the left vocal fold and the right vocal fold. See, I even have to do that all the time, even though I look at scopes all day. And then we've got our epiglottis cartilage, we've got our rytenoids, and then the airway down below and the esophagus there, but it's closed right now because we're not actively swallowing. So let's take a peek at the scope. Okay, so after watching that, what would you recommend? So we're going to do another little poll here. So would you recommend, and you can get your phones out with the QR code, what would you recommend? Voice therapy alone, so that being a primary treatment, right? So voice therapy only. Restylane injection only, and for those of you who don't know, it's a temporary filler that actually helps medialize that paralyzed vocal fold to the midline to help the other vocal fold that is moving reach it and vibrate in the middle. And then a medialization thyroplasty, so that's a permanent implant. We usually use either Gore-Tex or Silastic. And that again also medializes that paralyzed vocal fold. Voice therapy first and then Restylane injection. So that would be voice therapy as an adjunct treatment or Restylane injection and then voice therapy. So voice therapy also as an adjunct treatment in this case, but just switched. So I'll wait a little bit. And if you really don't see any voice patients, just give it a guess. We're all friends here. Okay, we're still climbing. I'll do it until we get to 100. Okay. All right, so let's look. So Restylane injection and then voice therapy. Awesome, that was the winner here. Voice therapy and then Restylane injection only, voice therapy alone. Okay, nobody wanted permanent. Okay, awesome. Okay, and I know they're still trickling in. Appreciate you guys. All right, so let's look. So when we look at the structural impairment here, right, we see that this left vocal fold is very lateralized, making it pretty impossible for the right vocal fold to meet it in order to vibrate for phonation. And functionally, that leaves a significant glottal gap, right, leading to a very quiet and breathy voice, as you heard. So in this case, if a laryngologist were asking me what I think, I would say, yes, voice therapy as an adjunct therapy And I would see if they would be willing to do a Restylane injection first, followed by voice therapy. We would really need a Restylane injection to help medialize that left vocal fold first before therapy could really be beneficial. It's also too early to do something more permanent like an implant, as it's been much less than a year, which is usually the cutoff when we say, okay, the nerve may not be coming back after a year, and because we know it wasn't sacrificed in the surgery. So it still may be a temporary paralysis. However, since the patient's quality of life is being significantly impacted, we would want to treat this in some way in the meantime. And of course, if they don't want to do a procedure, we could still offer them the option of personal amplification, et cetera. But if they're willing to undergo a procedure, that would probably be the best option for them. Okay, so what about this case? So this patient is a 60-year-old woman who also has paralysis, but it's idiopathic and on the right side. She noticed her voice difficulties about 6 months to a year ago. Her workup for any other reason for the paralysis has been negative, so no tumors, nothing else scary. Her symptoms are overall fairly mild, no difficulty swallowing or aspiration concerns, but she does experience vocal fatigue and difficulty projecting. So let's watch. Much shorter video.
E, E, E.
Okay. So what would you recommend for this case? The same or different?
E.
So same options here. And I wonder if it's because it's the same options, it's going to not reset it. We'll see. But if you guys want to go for it and try. And Brooke, I don't know if it's changing. So if people also want to use the chat, if they can't change their answer, that's totally fine too. All right, let's see. Okay, so voice therapy alone. Awesome. That was the winner here, Restylane injection and then voice therapy. Again, not sure if that's left over from the other one. Can't tell, but it sounds like a lot of people thought voice therapy alone. Okay, amazing. So yeah, I would agree. I would likely recommend trying voice therapy alone first, since that paralyzed vocal fold is in more of the median to paramedian position, makes good contact with the other vocal fold, and it could change, right? Depending on how much improvement they get with voice therapy, like our recommendation could change, or if that vocal fold changes position, which is always possible, but definitely a very different picture compared to last case. Okay, thanks for participating, everyone. All right, so as you saw with these two vocal fold paralysis cases, we don't always treat the same diagnosis the same way. Treatment may change based on the functional impairment, the symptoms, and especially the person, right? So let's start with addressing the functional impairment in voice therapy. There are many voice therapy techniques out there, and this is not even close to being an exhaustive list. So how do we choose? Well, before we can decide on what to start with, we must understand or at least hypothesize about the why. Right? Why are they having difficulty with their voice, or why do we think? Is it because there is a lack of coordination, a lack of vocal fold closure, perhaps too much laryngeal tension? Is there not enough airflow? Maybe there's too much airflow. And if we can determine this, or at least, again, guess, this will help us choose which techniques to at least start with in therapy. For example, if they have a lack of coordination with voicing, maybe we try semi-occluded vocal tract exercises, right? So that's our lip trills, straw phonation with or without water, voice fricatives, tongue trills. Lack of vocal fold closure, maybe phonation resistance training exercises, also known as forte. Excess tension, maybe some manual therapy. Not enough airflow, maybe stretch and flow. Too much airflow, maybe resonant voice therapy to kind of optimize the vocal fold closure pattern. But alas, there is no perfect formula. Oh, I wish. So in reality, a lot of these impairments can actually co-occur, and many of these voice exercises can work for multiple types of impairments. And there are many additional voice exercises that could also work for these impairments as well. Okay, so that is all to say, you've got to be strategic, but don't be afraid to pivot when needed. So when choosing a voice therapy technique, it's important to first determine the functional impairment. Again, as you saw with the paralysis cases, they had the same diagnosis, but two very different functional impairments. And you want to choose the facilitators based on the goal, whether that's to reduce tension, help coordinate the systems, improve vocal closure, or maybe several of these. If you're newer to the voice world, which sounds like a lot of you are in the voice world, but my recommendation would be to get to know the primary techniques and be able to demonstrate and troubleshoot them well yourself. Be able to do them yourself. So SOVTs, resonant voice, vocal function exercises, conversation training therapy, and I'll provide some resources at the end to help with this part. And then remember that even if a voice therapy exercise should, quote unquote, technically work, it doesn't mean you need to stick with it, as every patient will respond differently to different techniques. And it's important to be creative. If you've tried, quote unquote, everything, try something maybe you didn't think would work. So let's look at these concepts in a quick case example. So this patient is a 62-year-old woman with functional stuttering and shortness of breath with speaking. She had a normal medical workup, including with pulmonology and neurology. Not the most frequent voice patient you may encounter, but we all see some interesting cases, right? So I tried pacing strategies, tried SOVTs, resonant voice therapy, easy onset, etc., but I could tell she was just becoming really cognitively overloaded and nothing was sticking. So first, let's take a listen.
Good morning. Jeez. How are you? How are you feeling? See you soon. What's wrong with those people? I need your brain when it's available.
Okay, exhausting, yes.
Yeah, and I can tell the difference with not getting the breath going first.
That's right. So let's try it again, now with the focus on the crisp, clear speech. Overdo it, exaggerate it a bit.
Good morning. How are you? How are you feeling? See you soon. What's wrong with those people? I need your brain when it's available. Holy Moses.
Okay, so other than being absolutely adorable, interesting case, right? Also, those were her functional phrases that she came up with. I didn't just randomly make up those phrases. But turns out she benefited just from one cue, crisp, clear speech. And it seemed to coordinate her without her having to overthink her breathing like she was before. So just another reminder to be creative and to treat the person in front of you, not just the diagnosis. Okay, so we figure out the structural problem, we figure out the functional problem, we identify some exercises that the patient is most stimulable for improvement with. We're good, right? Well, we all know it's not that simple. So we know voice therapy has high attrition rates. More than half of patients don't return to therapy after the first session. Carryover to functional context is often really challenging for patients and hard to facilitate for therapists. And there are a lot of outside barriers to progress that are usually lurking in the background that we have to uncover. So what are some of these possible barriers to progress? Well, the severity of the physical impairment. Sometimes the structural issue is just too severe for voice therapy to be beneficial yet, just like we saw with that first vocal fold paralysis case. Self-efficacy or the lack thereof. The patient maybe doesn't believe they can do it. Lack of motivation. Maybe it doesn't affect their life enough. Maybe they just cared about if they had cancer or not. Maybe they don't care about their voice quality that much, or it's a family member that's kind of encouraging them, not really them. Difficulty with retention. So either not remembering the instructions or just not remembering to do the exercises throughout the day or how to do them. Fear of or resistance to change could also be related to a sense of identity as well. Mental health or emotional traumas, time barriers. Sometimes people's schedules make it very challenging to either practice or attend the voice therapy sessions themselves. And then financial barriers, whether that's access to transportation, insurance issues, or inability to pay copays or any other out-of-pocket costs. So I'd like to now review a case study that highlights some of these barriers to progress. So this is a 35-year-old female who had a 2-year history of significant dysphonia. The onset of her symptoms began initially with an upper respiratory infection, like many do. Eventually, her fever and other symptoms resolved. However, her hoarseness worsened, and she developed shortness of breath with exertion, difficulty swallowing, and episodes of feeling like her throat was closing. She had previously been trialed on gabapentin, but unfortunately couldn't tolerate the side effects. So by the time we saw her, she had been seen by 9 different doctors with no resolution of her symptoms and was understandably very frustrated. So this is what she sounded like when we first met her.
When sunlight strikes raindrops in the air, they act like a prism and form a rainbow. The rainbow is a division of white light into many beautiful colors. These take the shape of a long round arc with its path high above and its 2 ends apparently beyond the horizon.
Okay, you get it. So now let's look at her video stroboscopy, and I'm going to ask you what you think is going on next.
And again. Good. And then I want you to alternate between a sniff and an E like this. E, E, E.
E, E, E.
Good. Good. Hold out as long as you possibly can. I know you're doing good. Good. And can you do another E? Good. And then can you go he, he, he? He, he, he. Good job. Good. Do that again. You did excellent. Yep, do that again. And one more time. One more time.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
Okay, I know that was a little long, but I wanted you guys to see everything, including the connected speech, etc. So, again, with the polls, what is the most likely diagnosis based on that information? The history, the scope, etc. Vocal fold paralysis or paresis, muscle tension dysphonia, vocal fold atrophy, laryngeal dystonia, aka spasmodic dystonia, or something else. A little bit, okay. All right, let's see. It's the winner. Muscle tension dysphonia. Laryngeal dystonia came in second. Vocal fold paralysis, paresis, vocal atrophy, something else. Oh, I'm curious about something else. Okay, so let's look at our scope again, or at least the pictures. So I would say her vocal folds look pretty beautiful, right? The straight edges, good mobility, although that one's a little tricky with the scope, so we'll talk about that. But good color, but she's using a lot of effort, as you can see on the right? So much so that her vocal folds can't really tolerate that much subglottic pressure, and they're just coming apart when she voices. And then to compensate, she's using a ton of supraglottic squeeze on top of that. So the diagnosis that was given was indeed muscle tension dysphonia. So this patient was actually quite stimulable for normal voicing. after a while. We used a combination of optimizing her breathing, which I don't always start with, but I had a feeling we needed to calm down the nervous system in order to get the most benefit from the other voice exercises. And then resonant humming into chanting worked with a lot of cueing and negative practice. You saw me trying on the scope, but it wasn't quite working. And what worked really well for her was masking, meaning I would chant along with her to essentially mask her voice to see if disrupting her auditory feedback loop would make any difference. You can do this with headphones also. This is when I really started to hear her true voice come out underneath mine. And then I would just gradually take my voice away and then let her hear her own voice. And then we shaped that with CTT strategies, conversation training, therapy, crisp, clear speech to help balance that airflow and reduce the excess pressure that she was using. But that dysphonic voice would come back when we started getting into conversation, and she wouldn't really try to correct herself. So there seemed to be some sort of resistance to her wanting to change. So I thought maybe it was time to pivot. And when I was able to speak with her in the room alone, we were able to dig a little deeper, and I asked, okay, how would your life change if your voice could go back to normal today? Which I like to use this question, but obviously you have to approach it very gently. And this is what revealed some barriers to progress. So she opened up to me at that time and admitted that even though this was not initially a conscious thought of hers, she now realized that her hesitancy in getting better was that she recently found out about her husband's infidelity and was afraid that if she suddenly got better, she would lose the attention she was now getting from him with all of her medical issues. So this was obviously traumatic for her. We gently discussed the topic of seeking other services to help her work through this in order to address her voice and other throat symptoms. So we identified these two issues as the main barriers to progress: fear of or resistance to change, and emotional traumas, which actually turned out to be related. So fortunately, when I saw her back, she was actually from out of town, unfortunately. She had sought out both individual and couples counseling and was in a much better mindset. She had also been using the videos we had made together that I had asked if she would practice all these voice exercises at home on her own. And she was now successfully using her clear, easy voice in conversation without much effort. So let's listen to her voice afterward.
When sunlight strikes raindrops in the air, they act like a prism and form a rainbow. The rainbow is a division of white light into many beautiful colors. These take the shape of a long, round arc with its path high above and its two ends apparently beyond the horizon.
Okay, wish I could see her faces now, but as you can see, she sounds like a completely different person. And at the time of this recording, she reported that not only had her hoarseness resolved, but also her episodes of shortness of breath and throat closing. So that case demonstrates why this whole person approach matters, but let's talk about how we can maybe systematically and proactively address some of these in the context of another case. But when thinking about how to make sure we're addressing the whole person, we want to think about a couple things. Maybe building the therapeutic relationship, encouraging self-efficacy, want to address comorbid conditions that might be affecting the voice, consider life factors, of course, as we said before, create functional goals, develop a strong practice plan, right? So let's see how to apply this when we look at our next case. So this is a case of a 25-year-old female with ADHD. She works as a door-to-door salesperson. She considered herself a talker, is what she would say. Vapes every day, sings karaoke 3 times a week. She has chronic cough and chronic throat clearing, and drinks a significant amount of caffeine and not a lot of water. So let's watch the video of her scope. And I apologize, there's no sound on this, but I think you'll see what you're looking at. And then if you don't mind, again, you can write in the chat or just write it down for yourself if you want to test yourself. I don't have a poll for this one. So what do you think's going on here? Okay, so I'm going to see if I can stop it right at a good part where we can kind of Okay, so I want to give you guys a second to think about what you want. Thanks, Brooke. If you guys want to, yeah, put some stuff in the chat. Brooke's gonna let me know. Okay, someone has said nodules. Do people agree? Hypertension. Okay. Paresis. Edema. All right. Thanks. I guess we'll keep it there. So yeah, so this is kind of a good still shot here. So we can kind of see this hourglass shape, right? We've got a little gap here, bigger gap here. So we see something going on here. Bilateral mid-fold fullness / early nodules. Edema is not incorrect either, though. There's definitely some edema. We got a little redness here, right? Mobility looks good. But yeah, just a little of that mid-fold swelling right there. Okay, awesome. Thanks, guys. All right, so when we're thinking about possible barriers to progress, this patient had really all of these barriers at the beginning. So potentially the severity of the lesions could be a barrier, right? We did actually find something on the scope. Lack of self-efficacy and motivation initially. Due to her ADHD, she struggled with difficulty retaining instructions and organizing her time. Her words, not mine, actually. She also mentioned that she liked her raspy voice sometimes. So there was a potential resistance to change there. She did disclose that she had a difficult upbringing and was dealing with some other mental health and emotional traumas at the time. And she also had time barriers due to her very busy work schedule, as well as financial barriers that were arising due to upcoming insurance changes. Ooh, so how do we overcome these barriers? Well, first, we want to at least start by building the therapeutic relationship. And I really can't emphasize the importance of this enough, especially people who already work in this part of the field. Voice therapy is weird. And the person, especially if they're not a performer or a singer, is most likely going to feel pretty awkward. So making them comfortable with you first, I think, is essential to progress. So with that in mind, knowing the patient's history, there's some obvious vocal care issues here, right? However, if I came in starting to tell her, hey, you're going to have to stop vaping, stop going to karaoke, stop replacing water with caffeine drinks, and stop talking so much, she'd probably shut her computer on me. And I wouldn't blame her. So, first, I wanted to prioritize building the therapeutic relationship before even starting to address any of these vocal hygiene issues. And along those same lines, I wanted to validate her experience. We talked about her job and how that must be really tiring and stressful, having doors shut in her face all day and being yelled at every day. The story she would tell me. Ugh. And then really wanted to focus on what she wanted out of therapy so we could really tailor our plan to fit what she actually cares about and what will motivate her to put in the work to improve. So I also wanted to encourage self-efficacy along the same lines, right? Which we can do sometimes through stimulability testing. And the question was, could we get her voice to sound and feel a little better with some voice therapy exercises despite her early nodules? And for her, yeah, it turned out yes. Straw formation and some conversation training with negative practice did result in clearer voicing with less strain. And during this practice, I also wanted to allow her space to come to her own realizations so that she could build confidence that she could do it. Fortunately, she was able to appreciate a difference. And when she did, she even said out loud, hey, maybe I can improve with therapy, which is much more motivating than anything I could have told her myself. So once we established that she could improve, I wanted to make sure we addressed other potential comorbid conditions that could possibly be barriers to progress and incorporate them into the therapeutic plan. So for her, one of them was her chronic cough and throat clearing. So we worked on increasing her awareness, using replacement strategies, and discussed the connection between chronic coughing and her voice. And I also wanted to take into consideration her ADHD when finding ways to best support her learning style, preferences, and challenges. We always want to consider lifestyle factors, right, when coming up with a therapy plan, whether they're a teacher, bartender, coach, performer, maybe a retiree. So same thing for this patient. I wanted to consider her job as a salesperson and her social life to come up with a realistic plan for her. So for instance, performing her vocal resets during her drives and sipping water between houses ended up being pretty effective and realistic for her. We also brought awareness to how stressors at work and outside of work could be contributing to muscle tension patterns and how relaxation strategies could potentially help with this. Finally, we also broached the hydration and outside irritant discussion gently, educating her on saline nebulizing and other hydration strategies. And when we did, she was actually the one that came up with the idea of trying to replace vaping with saline nebulizing, which of course I thought was a great idea. But I think you may all agree that if I had suggested that right away, she may not have been as open to it. So this brings us to creating functional goals. It's not what we care about as the clinician, but what does the patient care about? We all know this, right? So for instance, in this case, the patient cared mostly about vocal endurance and reliability. She just wanted to get through her workday without losing her voice. And she also cared more about the sound of her singing voice than the sound of her speaking voice. And we know that sometimes by working on one thing, we could simultaneously address another, such as working on the speaking voice to help the singing voice or vice versa. But making sure that we're keeping the patient's goal in mind at all times will help keep the patient motivated as they'll care more about the outcome. Okay, and finally, we want to build a strong plan for home practice. So at the end of the session, does the patient know what to practice, when to practice, and what the goal is with each practice? I like to have my patients take their own notes to help with retention, incorporate their own cues, in addition to providing my own written audio or video recordings based on their preference. For this patient, she greatly benefited from repeating back instructions at the end of the session so she knew she understood them, and that's what she wanted to do. She also benefited from having reminders on her phone to check in with her voice and drink water, her nebulizer. And then finally, we wanted to make sure that we include a plan for carryover into real life situations, which we will talk more about in the coming slides. Also, I unfortunately don't have a post scope for this patient as she did have a change in insurance and had to take a short break from therapy, but I did provide her with some home practice resources for her that I'll share with you all at the end of this talk too. So that brings us to how we can help facilitate carryover to conversation for our patients, and this will be the last part. Okay, so like we said at the very beginning, bridging the techniques to conversation is one of the hardest things to do. So I like to talk to my patients about motor learning theory to provide reassurance that it does actually get easier with continued practice. So everyone typically starts at unconscious inefficiency. This is where the patient may not know that they're doing anything inefficiently, so how are they supposed to make a change? Then we can pretty quickly move to conscious inefficiency. This is when the patient knows they're doing something inefficiently, so their awareness has increased, but maybe they don't quite know how to change it yet. Then we move on to conscious efficiency. And this is where now the patient knows how to make a change, but it still requires significant cognitive effort. And this is probably the longest stage before we eventually get to our ultimate goal of unconscious efficiency, where now they're basically achieving their target voice naturally most of the time without having to think about it too much. Now, how we get there is like how we would learn most skills, like in sports. I am a tennis player, so this is the metaphor I'm going to use, but feel free to change it as you wish. So we start with drills. For example, learning how to hit a forehand in tennis. Maybe you practice on the ball machine where it's a much more controlled environment. That's where we can really focus on the specific skill we're learning without a lot of distractions or other factors. So that would be like our individual voice exercises or structured vocal programs. Then we scrimmage, like playing out some points with a practice partner. That's getting closer to applying these skills into a match-like situation, but without the extra pressure and distraction. So this might be reading aloud or even having a shorter, focused conversation with a close friend or family member, even for about 5 to 10 minutes. And then finally, we have the game. So now the pressure's on and we're all sorts of things going on, emotions, fatigue, other distractions, background noise. Now that's like conversations we have in less controlled environments, right? When we're out in the world with a variety of familiar and unfamiliar listeners, So when patients ask, well, how am I supposed to remember all of this in everyday life? It's a good question. I use this analogy and talk about, well, that's where the work goes in behind the scenes so that we're ready for the game. And that doesn't mean that you won't slip up and have to reset, just like we do in a tennis match. But you're right, the goal is to not have to overthink it when you're in those situations. So again, I'm hoping this analogy can help you all too in counseling patients, and feel free to make it apply to your patients or maybe something um, that you can relate to. Okay, so just for some final thoughts, I hope you agree now that voice therapy is much more than worksheets. It's very important to remain flexible and creative in our approaches. Of course, we always want to keep therapy as functional as possible. We want to consider all factors and possible barriers and then actively work to overcome as many as possible. Also, I just want to say here, before I forget, that if things are still really not working in therapy and you might be thinking maybe there's something else going on, either neurologically or structurally, or even if it really is a true muscle tension pattern, but they just might need some medical or procedural intervention to assist with therapy, that could fall under the severity of the impairment barrier. Don't be afraid to discuss further with your laryngologist or the general ENT you're working with, or even send back to them for another look. And finally, just like in our cases today, we probably wouldn't have gotten where we had without first addressing some of those barriers to progress. So if you're feeling stuck in therapy, don't be afraid to pivot. Okay. So here are my references, and I wanted to give you guys 2 additional references. So this, or resources, I should say. So this is the resource I was referring to earlier that I gave to my patient. The free app I made for my own patients originally, and then now I'm kind of opening it up to whoever might find it useful. It has a bunch of education on voice, cough, upper airway, as well as videos of exercises. So basically, you just have to download the Spaces by Wix app. Maybe you guys already have that. It's on the App Store. Make a quick free account and then either search for VoiceBox Rehab, or you can join with a code using K12DAB. I did not make up this code, it's what they gave me. And I also made a corresponding website if you want to look more into it later, at voiceboxrehab.com. So yeah, if you want to scan that, look into it, or take a screenshot and look into it later. And then the other one, this is another resource I've worked on for a few years now. We're finally done with the data collection, or actually opening it up for everyone to access now. So it's an online educational module on laryngoscopy and video stroboscopy. Has a bunch of videos and animations and explanations. Has little test your knowledge things. Has a lesion atlas, as well as a video on how to scope and tips and tricks for it. So hopefully this is helpful too if you're interested in learning more about laryngoscopy and video stroboscopy. So that's the QR code for that. And if you can't get it right now, let Brooke or me know, and I will give it to you later. Okay, thank you all. Any questions? And I'll stop sharing so I can see you.
Awesome. Thanks, Sarah. We do have some questions, so I'll go ahead and start reading those. One question that came in the chat is, I work in inpatient rehab and we don't have ENTs who can scope patients. What is my role in supporting voice patients in this setting? I've done vocal function exercises because I was told they're pretty harmless and usually provide a list of outpatient ENTs to follow up with. What are your thoughts?
That's a good question. And it's a very difficult one. I struggle with this answer, but I would say, yeah, in terms of, also we could talk about voice exercises and what's like the least, dangerous vocal function exercises are not dangerous, but I would use your ears and clinical judgment. But I would say if we can get visualization, it also depends on the history, right? So if you feel like there's anything in in their history that might be really concerning for anything like a cancer or maybe a paralysis or something like that, um, I wonder if there's any other outside general ENTs that you could potentially refer to in the meantime, and while they're waiting to get in with them, you could support them in either counseling or giving them strategies to help communicate in the meantime if that's their main concern. But yeah, I can also talk more offline if there's like a specific instance that people want to talk through.
One question that came in was for case study 1, what exact exercises were assigned? The person is interested in specific treatment exercises.
Yeah, so the first case study, let me look at what it was. Was it the functional stuttering one? Maybe that person can clarify.
Yes, if
For the
the
problem.
person sent it in anonymously. So if you are still listening and you want to pop that into the chat, then Sarah can maybe answer. There's another question, Sarah, about saline nebulizing. Can you explain what
Yeah.
it is, how a person does it?
Yes, big fan. So yeah, absolutely. So let me get this out the way. Okay. So yes, so saline nebulizing, I have one right here. So this is what it looks like. There's lots of different ones. Vocal mist is a very popular one that people use. So basically, you can use saline solution. I was thinking I had one right here, but they're these little pink vials, but they also come in other vials. 0.9% isotonic saline solution is what you want. You can get them on Amazon. They usually come in these 5 milliliter vials, and you can just put them in the top of the nebulizer here. And there's just like this very gentle, cool kind of room temperature mist that kind of comes out. You don't want to treat it like an inhaler. You don't want to go that's gonna make you cough. So you just want to breathe in and out through the device very gently and in a relaxed manner. So the purpose of this is that it's basically the best way to topically hydrate the vocal folds. As we know as speech pathologists, when we drink water, it shouldn't be touching the vocal folds. So really the only way to topically hydrate is to breathe it in, whether that's with a room humidifier, steam inhalation. The difference with a nebulizer is the particles are smaller. So the research suggests that maybe it's getting closer to our vocal folds than the other ones, a little bit more of a direct hit, as you can say. So generally about 10 to 15 minutes is what I recommend for people, and that's usually how much the 5 milliliters will last. And you could do it 1 to 2 times a day, depending on the patient. Yeah.
Wonderful. Okay, so a couple of people wrote in about the case studies. Someone asked about what was recommended for the case of muscle tension dysphonia.
Oh, the really severe one. Um, yes. So we had talked about, so that one, that's where, I hope this is the right one because I felt like we talked. So the resonant humming, and the masking, wonder if it's that one. So the masking is what I was talking about where I was actually humming and chanting along with this person. And then it was interesting how they couldn't really do it alone, but then when they were mimicking me and not really listening to themselves, that's when it was very helpful for them. And then they were starting to get that clear voice. I hope that's the right case they're talking about because I don't think there was another muscle tension case.
Yes, that's the correct one.
That's the one. Okay, yes. And then I was basically, and I could just show you really quick, although I have a sinus infection, so I'm not going to be a very good demonstrator today, but I was just having her chant along until we got into like a little bit of a rhythm. Good morning. 1, 2, 3. And then I was trying to get it more natural. 1, 2, 3. 1, 2, 3. Obviously having her feel for vibration and things like that. But that's when it started, where she was actually able to get it, which seems like it wouldn't work based on how severe she was. But I think with her not listening to herself, it helped.
Wonderful. Let's see.
Seeing some stuff pop up.
Okay. So someone said for the case study, I think this is the same case, but for
Oh
the
yeah.
case study, younger woman, she said she also complained of difficulty swallowing. Could you elaborate on how a trauma response may contribute to dysphagia as well as a voice disorder and whether or not that persisted in this particular case?
Yeah, excellent question. So luckily it did not persist. It also resolved. And this is where, and muscle tension dysphagia, it was basically feeling like things were getting stuck in her throat. Tightness with swallowing, effortful swallowing were her specific symptoms. And so once we were able to relax her larynx and I guess pharynx, that's when her dysphagia symptoms also resolved. So I think she was just holding on to so much tension in there that it was affecting her voice, her breathing, and her swallowing at the time. But yes, muscle tension in that area can affect all of those things because Throat is a very important apparatus.
Another comment is we were trained on stroboscopy, but stopped completing them due to poor referrals. How would you suggest increasing referral rates? Also, for those who are just starting in voice, is there a good starting point that you can recommend?
Yeah. Okay. So to talk about the first part of the question was if they don't
Increasing referral rates.
referral rates. Right. Oh, you guys have good questions. Okay. Increasing referral rates. Well, I would say thinking about, what are the hospitals and private practices and things in the area that you are in, and reaching out specifically. Now that I'm in Maryland, I've been like trying to get to know, the other clinicians in the area. I even have like meetups and try to, reach out to some people. So I would say actually reaching out, finding out who are the ENTs or the laryngologists in your area, and reaching out, say, hey, I'm here, if you need somebody, right? And maybe it's not even just the laryngologist, maybe it's like primary care providers and things like that, because that's actually maybe where you would get more of your referrals. So yeah, I would just kind of see who's in your area and reach out to them. Don't be afraid. Oh, wait,
The
there was a
next,
second part of that. I'm sorry. There's a second part of that.
yeah, starting
Thank
point
you.
to learn about voice.
Oh, yes. Um, so kind of like what I was saying, I think the getting to know some of the main ones, like I would say SOVTs. So in terms of like voice therapy, SOVTs, resonant voice, vocal function exercises. Um, I mean, to be honest, when you get really familiar with those and conversation training therapy, you can tell I'm a big fan of that. There's a really great paper with Amanda Gillespie and Jackie Gardner Schmidt, about their conversation training therapy program. Definitely recommend it because they actually talk through and write out the exact steps of the therapy. So I would definitely read that paper. And it's actually pretty easy to implement. And it can work with a lot of patients, maybe especially if they don't have like a huge structural impairment. So a lot of our muscle tension patients, et cetera. Get really familiar with those. There's hopefully my app is also helpful getting to know some of those techniques. And then actually, if you're interested in learning about the video stroboscopy, that's also for you, the resource. So I think that'll be a good, hopefully, intro. And I'm also here as a resource if anyone wants to reach out.
This should be an easy one. What voice analysis equipment and software to use?
Oh, well, it's actually changed. So when I was at Mayo in person, we used CSL, computerized speech language software. What does it even stand for? CSL and then PAS for aerodynamic measures. Um, And then I use Pratt now, actually. And it's a little tricky because I'm all virtual now, believe it or not. So I will have people actually make recordings on their phone, and I have specific, instructions for that and specific tasks. And then I have them send it to me, and then I analyze it through Pratt. And that's a free, downloadable acoustic analysis software, which is really nice. So if you don't have a lot of access to other things, Pratt is a great Praat, so 2 A's. That's a great resource.
Okay, we only have 2 more minutes and there's a lot of great questions. So I'll have you answer one more, and I apologize if your question was not answered. Sarah is amazing and I'm sure we'll be happy to chat more. You can send me an email and I'll send them over to her. But this question is, can you talk more about treatment strategies for vocal fold paralysis in conjunction with injections? Thank you.
Okay, yeah. So I would say when we're thinking about treatment for these patients, right? It's if they're medialized and the vocal folds are making good contact, one, they may not need a lot of voice therapy. Maybe they're actually fine now. But if they are still compensating by squeezing, we kind of treat it similar to like a muscle tension dysphonia, right? So we're basically trying to unload that excess tension that they feel like they used to have to use because they couldn't get good closure. And now they are medialized, but they're still squeezing really hard. So a lot of times I end up using kind of semi-occluded vocal tract exercises or resonant voice therapy, humming into chanting, or even just conversation training therapy, depending on the severity of the muscle tension. So it does depend, but it also matters how much they're squeezing. So I would always, first of all, listen to their voice after the injection, and then if you can get a look and see what their kind of compensation pattern is, then that might also lead you to the right exercise or strategy.
There were a couple of questions in the chat about the article that you referenced, and I see that Dee mentioned that Amanda and Jackie, who are the developers of conversation training therapy, are starting a course online. And it
Yes,
sounds like
they are.
registration opens April 1st. So,
That's right.
and I think they just did I believe it was earlier this year, maybe, or at the end of last year, they did a podcast on the Swallow Your Pride podcast. So check that out
Yeah.
if you are interested. It was a great episode.
Yes,
And
and
then
MedBridge. Jackie does a really good one on MedBridge on conversation
there,
training. Maybe Amanda too.
before we log off, Sarah, there's a quick question about your Wix app.
Oh yeah.
Jessica said, oh, can someone type the name of the Wix app into the chat? And Jessica, I'm going to upload this recording and it has a QR code. So you'll be able to scan it.
Yep. And it's called Voice Box Rehab. If you want to look at it through Spaces, you can type that name in. But yeah, I think the QR code might be the easiest.
Awesome. Well, just a quick recap before we log off. If you are wanting ashes to use for this presentation, we ask that you fill out the survey, which I will pop back into the chat here. And that will be open. Let's see, today's Tuesday, so it'll be open until next Tuesday. And then this replay will be up on our website. So if you missed anything or you want to go back and rewatch, this will be available on our website. And if you would like a certificate of completion, just send me an email at tims-univ@tims.com. I had to think about it for a second. And we appreciate you joining us this evening. Sarah, thank you so much for your expertise. And thank you all for learning about voice with us.
Awesome. Thanks everyone.
Awesome. Bye, Sarah.
Bye.